Good afternoon, everybody. I'd like to add my sincere thanks to Julio for organizing and hosting a wonderful conference. Your national airline, Air Canada, amused me this morning as I logged in, checked in online. It asked the question, do you have antlers or a hunting trophy in your luggage? And I felt, at the start of my talk, I need to declare I have no conflicts of interest, no antlers in my luggage. And I think the hunting trophy that I'm leaving with is a new optimism that we do have some way of moving forward to address the HIV epidemic and TB epidemic, which is devastating sub-Saharan Africa. So thank you for that hunting trophy. So I'm talking to you about ART for TB control. TB remains a huge global health problem. Of the 1.1 million people with HIV-associated TB each year, 82% are in sub-Saharan Africa. And of the 350,000 deaths, 3/4, again, are in sub-Saharan Africa. And it's a common misconception that Mount Kilimanjaro, pictured here, which is 4 miles high, is the largest mountain on the African continent. Now, it is large, but it's climbable. 4 or 5 days, you can get to the top. It's hard work, but you can get there. There is, in fact, a larger mountain to the south of this mountain. This is in northern Tanzania, and it's this mountain here, which is the HIV-associated TB epidemic, which since 1990 has just risen inexorably. And it is proving extraordinarily hard to climb. And the little downturn is nothing due to what we've intervened with. It simply reflects the evolution of the HIV epidemic itself. So where is this huge mountain? It's right in the southern part of Africa. And I really want to focus today on what can we do about this? And what role will treatment as prevention have for this epidemic? Let me tell you how bad this is. This shows estimated TB incidence rates in South Africa, 981 per 100,000 per year. That's 1% of the population each year developing TB. That compares with UK, with 17, USA around 4.1, Canada 4.7. Just staggering magnitude of disease each year. If you think about the United States and Canada, with a population together of 350 million, they're around, 12 or 13,000 cases of TB each year. Now, I've been working for the past 7 or 8 years in Cape Town, a city of 3.5 million people, 100-fold smaller population, and yet each year we have 30,000 cases of TB. More than twice what you have in the whole of North America each year. And here we've shown the numbers of cases stratified by HIV status: green, HIV positive; blue, HIV negative; and purple, we don't know. We need interventions. We need radical interventions to tackle the HIV negative TB epidemic, which is probably driving, the main driver of the HIV that's fanned into flame by HIV. It's like pouring fuel on the fire. We need radical interventions because DOTS just isn't doing it. So what can we do? Just going to think through 4 sort of major interventions. Ultimately, we've got to sort this out. We won't get on top of TB if people are living in conditions like this. So, Julio, when you've sorted out treatment as prevention, if you can tackle this, that would be great. So that isn't going to happen anytime soon. Active case finding is really needed to trawl out TB from the community and switch off transmission. We know that we need to do that, but data about how to do this are still evolving. It's difficult. It's labor-intensive, and it isn't going to happen anytime soon. So there's no quick fix with active case finding. I think policy is evolving as we speak. The 3 I's policy, really important step forward. Intensified case finding and infection control, vital for reducing HIV-associated TB deaths and for making HIV care and treatment clinics safe places to deliver treatment. We have to get this right to make treatment as prevention work without fanning into flame the TB epidemic. What about IPT? Why don't we just use mass IPT and just, that will damp it all down? Well, there's data now from South Africa showing that a mass intervention with IPT in the whole mining communities, HIV negative, HIV positive, has absolutely no impact on TB prevalence or TB incidence. So again, this will not cut it as a mass intervention. But that takes us to ART. Will ART help? And that's what the focus of my talk is this afternoon. I'm going to tell you about good news, bad news, the real news, the potential for better news. And then after that, I'll talk a little bit about what HIV seroconversion, what impact does that have on TB incidence and drug-resistant TB. So the great news is these are data from Cape Town. ART, compared to the pre-ART era, has a roughly 80% reduction in TB risk associated with it across a broad spectrum of baseline WHO stage and CD4 cell counts. The 350 we'll come back to. That wasn't significant in this study because of small numbers of people, but we'll come back to that. This is really good news. This shows data from Guguletu cohort showing a time-dependent reduction in TB risk. And if we put together data from 6 different cohorts, you can see that most of the benefit is in the first 1 to 2 years of ART. Here's a meta-analysis of studies from high-income and low-income countries. All these data say this is good. So reduction in risk between 54 and 92% protection from ART, with a summary estimate of 67%, a 2/3 reduction in TB risk. That's phenomenal news. The dominant risk factor for TB on ART is your CD4 cell count. Viral load has a bit of impact, but really it's what your current CD4 cell count is at any given time that is the prime determinant. And that has huge implications that when we're thinking about test and treat and our CD4 health of our population. So here's the CD4 health of our ART cohort, baseline compared to at 48 weeks. And we can think of the amount of time that people spend in different CD4 cell count strata, and then we can calculate TB incidence rates not by duration of ART, but more importantly, according to your current CD4 cell count. And these measurements are made every 4 months in our cohort. So you can see that at CD4 counts below 200, TB risk is sky high. As ART drives your CD4 cell count up, the rate comes down to around 5% per year between 200 and 500. But risk continues to fall thereafter. There's an additional incremental benefit of going above 500. So the goal really to minimize your risk is to get your CD4 cell count as high as possible. Here I've done an illegal maneuver, stitching together natural history data, showing the rising TB risk as CD4 cell counts fall from 500 to 0. And then magically our cohort survives and starts ART, and the risk comes down. The point of this slide is that the TB risk associated with HIV is largely reversible by ART, and that's encouraging news. That's all the good news. It looks wonderful. What's the bad news? The flip side of the coin is when we looked at the first 1,500 or so patients in our cohort in Guguletu and looked at how much TB they had coming into the program, around half had had a history of TB treated in the past, 30% had prevalent TB at baseline, so that already at baseline, 2/3 of our patients have already had 1 or more episodes of TB that by definition we can't prevent. And because patients are starting at such low CD4 cell counts, there's an ongoing incidence of TB over the first 5 years, accounting for, well, a cumulative risk of over 80%. Ludicrous. So we're not using ART here to prevent TB. We're starting it way, way, way too late. So just to go back to this slide, people are entering the red box, the danger zone. And that's where we're diagnosing them. That's when they're starting ART. And so, surprise, surprise, clinics are swamped with patients with TB. This slide is encouraging in that it shows a falling TB risk. It's also very discouraging in that if you look long term, the rate is 5% per year. Now, a fundamental truism is that if people do not receive ART and they die, they stop getting TB. If you keep them alive, a side effect of being alive in sub-Saharan Africa is that you carry on getting TB. So in South Africa, there are 5.5 million people who in the long term are going to need ART, and if they're all getting TB at a rate of 5% per year, that's one a heck of a lot of TB. And so paradoxically, maybe ART scale-up will make the HIV epidemic, HIV-associated TB epidemic worse. Possible. So why does the rate remain so high? Well, it all depends on the CD4 cell count strata that patients are in at any given time. And this shows how patients change over 4 years of ART. At the bottom there, you see patients in the CD4 stratum below 100 falls, but plateaus at around 2–3%. Below 200, it falls from 80% to around 10–15%. So you can see the proportion of patients at any given time will determine the TB risk. And to simplify that, so at 4 years, 10% or less than 200 will have a sky-high TB rate. Between 2 and 500, 45% will have an intermediate risk, and the highest category will have the lowest risk. Added all together, the rate comes out at 5% per year. And long-term, that's what it is. And we'll follow the CD4 dynamics out. It remains at 5% per year. And in this recent publication we just put out last month, long-term patients followed up between 5 and 8 years. Guess what? The rate's still 5% per year. And if you look at our best patients, those with a CD4 cell count above 700, we look at all person time above 700, guess what? The rate is still 4-fold higher than the rate among HIV-negative people. You do not get back down to baseline risk. So although ART substantially reduces TB risk, it doesn't go back down to normal. That's the bad news. The good news, what about the real news? Now, cohorts aren't communities. The real issue is what happens in communities as you scale up ART. So these are data from Masipur-Maleli. It shows rising TB notifications. Notice it peaks at 2,500 per 100,000 per year, 2.5% of the population getting TB every year. With ART scale-up, this is numbers, 30% of all HIV-infected people in that community represented here on ART. There's an inflection, a sharp inflection. And here we've disaggregated the data by HIV-negative people, flatlining, HIV-positive, that's the inflection. Ignore the dotted lines, they're just sensitivity analyses. And if we disaggregate that further, it's the patients on ART in whom the risk is plummeting. Not surprising. And this shows the prevalence of TB, active case finding, sputum induction, liquid culture of a representative random sample of the population done pre-ART and then after ART scale-up, 3 years of ART scale-up. No change in HIV negatives. That epidemic seems to be dissociated. Among HIV positives, a roughly 2/3 or 3/4 reduction in TB prevalence. That's a dramatic effect at a population level. And these are data from Malawi, again showing in a district rapid scale-up of ART, a downturn in TB notifications. So we've got two populations where, despite all that bad news and the potential for paradoxical worsening of the TB epidemic, we are seeing benefit. And actually, I think that the benefit of ART goes beyond the CD4 cell count health and viral load suppression. I think there are other things happening as well. I think that the intensive case finding that we do pre-ART and during ART is good for patients. The impact on TB transmission, I think there may be an additive benefit beyond what we're seeing. And in Masipur-Maleli, I think the reductions that we're seeing aren't all explained simply in terms of CD4 cell count health. I think there's an extra benefit, and it'd be great if we could quantify that. And there's also extra potential as you have hundreds of thousands of patients in care. Potentially, they could receive IPT as well. Those who are TST positive will benefit from that and get further reduction. So having all these patients in care is good for them in reducing their TB risk as well, as long as you've got good infection control. What's the potential for better news? Clearly, we need to keep people out of this red box. We need to skip over that. We need to diagnose people at high CD4 cell count, start them on ART, and get them over here, and avoid the bad news era of below 200. And data to support that, data from CIPRA study from Haiti, the randomized trial we've seen presented numbers of times. Remember, there was a halving of TB risk by starting at 280 compared to 180 or whatever it was below 200, a halving of TB risk. And then again from HPTN 052, there was a 41% reduction in clinical events. Much of that was extrapulmonary TB, as reported in the paper. People got tangled up with that. Ignore extrapulmonary. That is a reduction in TB, and data will be presented at IAS in July to clarify that. There was no standardized case definition. There was no standardized method of diagnosis of TB. Patients with extrapulmonary and pulmonary TB were called extrapulmonary TB. Just there's a reduction in TB, okay. At high CD4 cell count, starting ART, there's a reduction in TB risk, which is hugely good news. And we added those data into a meta-analysis of studies from resource-limited settings, which showed that across all CD4 cell counts, 65% reduction. These are unpublished data, they're data on the way, which agrees entirely with our original 67% reduction. So our systematic reviews and meta-analyses agree. But here we've stratified it by CD4 cell count. 84% reduction in TB risk for patients starting below 200, 66% reduction between 200 and 350, and really importantly, above 350, a 57% highly significant reduction. Starting ART as early as possible is good for reducing TB risk, period. So, impact of treatment as prevention on TB control. Dual mechanisms, reduce time at low CD4 cell counts and the other benefits of being in care, but also an impact on HIV incidence and prevalence, which none of the other TB control interventions do. That's the magic of this. In the long term, we're also switching off HIV, which is the fuel on the fire for the TB epidemic. And these are data that Brian Williams has modeled with Ruben and colleagues at WHO, which is a really important analysis. The flat line, the blue line at the bottom, is HIV-negative TB. That's dissociated from our HIV-TB epidemic. It flatlines. The red line shows HIV-associated TB, which between 1990, that's our mountain. But the mountain can be tackled by early initiation of ART. And if you just focus on the red line, that's HIV-associated TB. The earlier you start, according to CD4 cell count, the more rapid the decline of the epidemic over a 2050 timescale. And here I've summarized it in the short term by 2015, starting ART on all patients within 5 years of seroconversion, a rough halving of the numbers of cases. Long term by 2050, the earlier you start, 5 years compared to 2 years, a 95% reduction compared to 66. So starting earlier, within 2 years of seroconversion, is great news. Tightening up further doesn't make an awful lot of difference, but over 90%, 95% reduction in this epidemic over that timescale is huge news, and I think this is very plausible. Not necessarily deliverable, we don't know, that's what we're discussing, but very plausible in terms of the effect. So treatment as prevention offers very plausible prospect of making a substantial contribution to control of the HIV-associated TB epidemic. And this seems to me the most plausible intervention that we have at the moment. I'm going to very quickly, last few slides, what about HIV seroconversion? The dogma is that HIV seroconversion leads to a rough doubling of TB risk. Now, I don't know if that is true. The data were from the mines, where there's such a swamping of the population with TB that for seroconversion to have a measurable effect is maybe being drowned out. The incidence rate ratio, HIV positive, HIV negative, is just 2.9. Wow. Minors testing HIV positive because of TB were excluded from the analysis. So there are some caveats with these data. I think it may have been underestimated. And the reason I say this is data from Sarah Lodi at the MRC for the Cascade cohort, showing that in Europe, this is purely cohorts from Europe, the TB risk in the first year of ART was 600 per 100,000. Now, they don't have data before seroconversion, but I think that's more than twofold. I think that's high. And again, that's conservative. They've excluded some TB cases diagnosed in HIV-infected people at baseline. So there's a question mark there, and if you think of people, the huge immunological insult of primary HIV seroconversion, it would stand to reason that there might be some reactivation of TB. If you give people TNF-alpha blockers, 6 weeks later, hey presto, they'll get TB. So I suspect that some of that is happening under the radar, which might undermine the impact a bit. So we need more data on that. What about drug-resistant TB? I'll put it to you that ART is probably no respecter of mycobacterial drug resistance. ART isn't going to say, oh, drug-resistant, I can't do it. No. It's just immunologically mediated suppression of mycobacteria. It will happen for drug-resistant as well as drug-sensitive TB. So just quick comment on the devastating epidemic in KwaZulu-Natal in South Africa, reported in 2006. sort of the advent of XDR-TB. That's when it really surfaced in our consciousness. What I want to just comment on is that within this epidemic of MDR and XDR-TB, this was HIV-associated TB epidemic. It was among patients with very, very profound immunosuppression. Very few of them were on ART, and most of them had had drug-susceptible TB within the previous year, and the opportunity to start ART had been missed. This epidemic was among people without ART with profound immunosuppression. If ART had been scaled up aggressively with good infection control, I suspect that this epidemic could have been controlled more rapidly. So I think here we have another tool to address the MDR-XDR epidemic in South Africa and other countries. We started with Mount Kilimanjaro. I'm going to finish with Table Mountain. This is Groote Schuur Hospital in Cape Town. This is Table Mountain, the foothills or the lower slopes of Table Mountain. This is fire season. You know, we have bushfires every, March, February time, very dry grass or whatever, And this reminds me of the epidemic, the HIV-TB epidemic. Very difficult to put out once it's started. And I'd put it to you, we need multiple interventions. There isn't one single trick that will do this. But among all these interventions, DOTS, early TB diagnosis, MDR diagnosis, intensified case finding, infection control, IPT, ART is absolutely key because this is the single intervention that will also dial down the HIV epidemic, which is what is desperately needed to control this epidemic. Thank you for your attention. I'd like to acknowledge all my colleagues in Cape Town with whom I work. Thank you.